Good afternoon, everyone. My name is Emily Moore, and I am the Senior Analyst of Health Transformation at the Association of State and Territorial Health Officials, also known as ASTHO. I would like to welcome you to today's webinar on telehealth and improving access to care in rural and underserved areas. ASTHO is committed to supporting state and territorial health officials and their leadership teams in transforming the public health and healthcare system. ASTHO, with support of the Health Resources and Services Administration, is hosting this webinar to facilitate the sharing of best practices and lessons learned related to telehealth. This webinar is scheduled for an hour and a half and will have time set aside at the end for discussion amongst participants and for the presenter to answer any questions. If you have any questions during the call, you are welcome to post it to the chat box on your screen at any time. These questions will be answered during the Q&A at the end of today's presentations, and we will also take 1 to 2 questions after each segment. We will also open the phone lines during the Q&A session at the end for you to ask additional questions. At the conclusion of this call, you will be directed to an evaluation survey, and we hope you will please take a few minutes to complete the survey, as we appreciate any feedback you have to help inform future ASTHO work. Now I would like to review the objectives of today's call. Our goal of this webinar is to provide a snapshot of telehealth activities ongoing in states from a national perspective, describe the policy framework necessary for public health agencies to support the infrastructure of a successful telehealth program, describe Hawaii and Alaska's telehealth initiatives, and also discuss with you about your work regarding telehealth and state health departments. Now I would like to introduce the speakers of today's webinar. The first speaker will be Latoya Thomas, who is the Director of State Policy Resource Center for the American Telemedicine Association. In this capacity, she works with ATA members, affiliates, and state officials on the legislative and regulatory issues affecting the use and deployment of telehealth services. Prior to joining the ATA, Latoya worked as an Associate Director of Governmental Affairs for the National Association for Home Care and Hospice to advance the use of technologies within the home health care industry, and also to ensure equitable access to health information technologies for all involved. She served as a research and communication strategist for the National Health IT Collaborative for the Underserved to promote their core message of using health IT as a tool to reduce health disparities and improve patient engagement and access to care. Our second speaker is Lauren Kim. He has 20 years of progressive leadership responsibility in the private and public health care sectors, as well as in managed care and public health. He has significant expertise in health policy, behavioral health, chronic disease, rural health, and health information exchange. Lauren has been the Chief in the Office of Planning, Policy, and Program Development at the Hawaii Department of Health since 2009. In this role, he provides leadership for agency-wide government relations, strategic planning, and special projects such as Hawaii's Telehealth Initiative. Our third presenter is Jill Lewis, and she has 20 years experience within the state of Alaska. Since 2009, she has been the Deputy Director for the Alaska Division of Public Health. Her areas of focus include financial management, legislative affairs, administrative services, strategic planning, and performance improvement. She oversees the chronic disease prevention and health promotion work, as well as rural health planning and systems development and vital statistics. Jill is active in several ASTHO peer groups, and in addition to the Senior Deputy Committee, she is a member of the Chief Financial Officers, Informatics, Legislative Liaisons, and Performance Improvement Work Groups. Prior to joining the State Public Health Agency, she supervised the state Medicaid budget and worked as a labor economist and researcher. She's a graduate of the University of North Carolina. Christiane Staff is the Telehealth Program Manager from the Alaska Department of Health and Human Services, and we're excited to have all these wonderful speakers joining us today. So without further ado, I will turn it over to Latoya to give us the national perspective. Thank you so much.
Thanks, Emily, and thanks to ASTHO for having me on the call. I'm more than happy to go over what states should expect from a policy infrastructure to advance the use and adoption of telehealth in this space. Just a little background by way of who ATA is. The American Telemedicine Association is a 501c3 nonprofit member-based association with one office here in Washington, D.C. We are the only fully staffed international organization in the world dedicated to the advancement, promotion, and integration of technology and telecommunications in the healthcare space. We do a variety of things, policy being one of them, but we also have a very engaged and broad membership that is organized into chapters and special interest groups. And we're actually meeting in an upcoming meeting at the end of September in New Orleans, and it's open to the general public. But our focus this year is going to be on disruption, so just wanted to offer that to folks who might want to get better insights into telehealth. We're also putting on a town hall focused on the southeastern states and the ways in which they can better leverage telehealth in their respective communities. So I just want to start off with just a general broad definition of telemedicine and telehealth. We define telehealth and telemedicine as services provided via telecommunications from one location to another. And the various models that might employ telehealth include peer-to-peer, provider to patient, or even in a supervisory capacity, having a provider using telecommunications to supervise a mid-level professional. And as said, the value of telemedicine can't be understated. With such a broad definition of the use of the technology and telecommunications in this space, telemedicine has been shown to reduce time and distance barriers, alleviating professional shortages, as well as getting to the issues of alleviating disparities in access and availability of care, enhancing quality of care and outcomes related to that, reducing unnecessary hospital admissions and emergency room use, enhancing reducing the overall costs associated to healthcare delivery, and of course, getting at the heart of ensuring convenience and patient choice. And as new clinical models are developed, what we are seeing is states responding to the leveraging of telehealth by reforming some of their state policies. What we've seen across the board, whether it's state entities, both public and private, removing government barriers. This might be in the form of antiquated language that may have originally allowed for the deployment of services in person, but not necessarily through the use of telecommunications, permitting healthcare providers to use or deploy healthcare services across state lines, or just generally allowing a healthcare provider to use the service in lieu of an in-person visit. And of course, one area where we've seen a tremendous amount of growth from a policy standpoint is the allowance of telehealth as a way of delivering care and being covered under a health insurance plan, and of course, having said service being reimbursed as well. And so what we're currently seeing from a state level in terms of looking at some of these opportunities and goals is just a lot of momentum. As a result of the federal agency, CMS, not having any statutory or regulatory guidance with regards to telehealth provided services, we have seen Medicaid agencies primarily serve as incubators for telehealth provided services. There are currently 49 states that have some authority to cover and reimburse for telehealth provided services, and it varies across the board. The one state that we're aware of that has no current coverage of telehealth provided services is that of Rhode Island. But all of the other states in some capacity either reimburse for, cover and reimburse for imaging, or if they decided to identify, currently cover and reimburse for existing services covered under their plan, but are delivered via video conferencing and extend that to those who are enrolled in their Medicaid plans. The one new state that we were happy to see come on board is that of Connecticut, which enacted some legislation earlier this year that made it number 49. We've also seen states innovate a little bit, maybe not covering services via telehealth under their fee-for-service, but doing so through their managed care, and we're seeing that in states like Massachusetts, but certainly there's some room for growth there. Now, as those states are leveraging telehealth, as I mentioned, we are seeing a lot of variance. One of the things that we have seen over the past few years is that even though there is no federal oversight specifically as to how a state can cover and reimburse for telehealth under their Medicaid plans, and there appears to be a baseline just for the services generally that are provided. What we are seeing is that to the degree that states themselves are regulating telehealth is across the board. There are states that unnecessarily prescribe where a patient needs to be as a result of their own due diligence to maybe clamp down on certain coverage and reimbursement for the service. And there are some states that may or may not require a facilitator or a telepresenter at the location of the patient. There are states that may or may not create a menu set of the types of services that are covered or reimbursed, or the types of healthcare providers that are allowed to render such services. But essentially what you've seen here is just a snapshot of us capturing that information, making it available in a report that we have freely available on our website. But as you can see, by and large, states have made a lot more progress when compared to that of Medicare and the way in which Medicare covers telehealth provided services. States largely have very little restriction on the basis of rural distinction. There are a couple of states out there that may impose restrictions on that of mileage, but as of today, there aren't any state Medicaid agencies right now that restrict coverage for telehealth provided services based on one's geography. And again, you can indicate that states having much more flexibility because of the lack of federal oversight on this as opposed to that of Medicare. And I anticipate that these grades will probably change in the next few years, especially as states are looking at more value-based alternatives, whether it be in the form of capitated payments or other bundled solutions when it comes to delivery and payment reform. I anticipate that telehealth will certainly be a tool that they leverage as they look for more value-based alternatives, and I imagine some of these grades will probably change as well. As we talk about the lack of federal guidance and federal oversight and ways in which states have essentially been able to leverage their flexibility to provide and cover for telehealth provided services, one of the things that we've seen in tandem is commercial insurers also doing the same. And so what we have today is about 31 states and the District of Columbia who see the value in telehealth, and as such, state lawmakers have decided to require that commercial insurers cover and reimburse for services provided remotely or via telecommunications to the same extent that they are doing so for in-person services. Of course, the interpretation of these laws vary across the board, but the fact that state lawmakers see the value in telehealth and that the insurers that are regulated by their state see the value in telehealth, I think just bodes well for those who still have yet to enact such laws. And again, as Medicaid agencies are looking at value-based alternatives for payment reform, I think that they're going to leverage some of the work done by some of these commercial plans to integrate telehealth into existing plans. As of this year, and I know that you're going to hear from some of the states in the next few minutes, but Alaska and Rhode Island were the two states to enact legislation this year, again making it 31 states and the District of Columbia. The state to first enact a parity law, interestingly enough, is that of Louisiana, and that was done in 1995. So we've seen significant momentum on the parts of states, again, to knock down some of those the discriminatory provisions that wouldn't allow the coverage of such services when delivered remotely, but now allowing much more patient choice in this matter than we've seen before. Something else that you should probably keep in mind, especially as states are transitioning from a volume to value, is CMS's decision, again, earlier this year to reiterate their stance that they are not going to regulate telehealth any differently than they would for in-person for Medicaid, is the recognition of the role that telehealth plays in network adequacy. So states are looking at volume to value and are looking at ways in which they can ensure adequate provider networks to provide services under some of these healthcare plans, I'm sure that they're going to continue to look at telehealth as a way of alleviating provider shortages and making services available and accessible to those that are enrolled in their plans. So just something to be mindful of if legislation is introduced in your particular state. I know that there are some states and insurance commissions that are already having those conversations. One other area in which states are seeing the value in telehealth and as a result are responding with some policy reforms is that with regard to licensure portability. As it stands right now, especially when it comes to non-federal initiatives, a healthcare professional has to be licensed in the state where the patient is located in order to render services either in person or remotely. The exception to that obviously is some of these federal programs. The Department of Defense has a one license rule. If you are an enrolled provider in the healthcare plans that have oversight by the Department of Defense, one license is all you need in order to provide services throughout the country. There have been congressional efforts in the past few years to ensure similar licensure models for other federal programs, with congressional bills introduced for those who are providing services to the VA, as well as those enrolled providers for Medicare. Unfortunately, neither of those bills have made any drastic improvements this year, but there certainly is efforts to reintroduce this legislation in the hopes that we can have, at least for federal programs, provided by providers for Medicare and the VA, a one-state license model. Now, for those non-federal programs that are regulated by the state, what we are seeing are providers looking for solutions that get at some kind of mutual recognition or state acceptance that would allow for a provider to go seamlessly from one state to another, whether or not they are traveling or using technology. The Federation of State Medical Boards has created a compact that would allow an expedited licensure model. 17 states have joined this compact as of yet, and essentially what the model would do is it would allow for a physician to apply for a license and have that license process expedited so that the physician can practice in the state in which they're applying. There are other models out there that are based on mutual recognition, and these models are being seen by groups like nursing, physical therapy, and psychology. The model of mutual recognition is as such that if you apply, that if there are states that are joined into a compact, then a healthcare professional that is applied to and have their application license approved in a state that has joined that compact does not need to apply for additional licenses in other states that have joined the compact. The nurses are a group that have probably the larger success of this and have since enhanced their compacts for RNs and have created a new compact for APRNs. And of course, now we have compacts geared towards psychologists and physical therapists based on that similar model that would alleviate the licensure application burden for those healthcare professionals. Something just to be mindful of, especially in the upcoming legislative session, again, that would support the adoption and utilization of telemedicine and telehealth in your state. One other area to be mindful of is that of clinical practice, especially for state agencies whose role it is to provide some kind of oversight to licensing boards. It's one thing to approve the license of someone to clinically practice in the state, but there have been efforts on the part of some boards to create harsher standards for telehealth or telemedicine providers than that of in-person, those providing in-person services. We have gone through an extensive education and outreach initiative with licensing boards across the country. And if you can imagine just your general set of marriage and family therapists, your counselor, to your physician and nursing groups, there are over 400 plus licensing boards throughout the country whose responsibility it is to regulate the clinical practice for certain professionals in that particular state. Our message to them is fairly clear, to uphold the standard of care and to not create additional standards for someone just because they're using a technology or tool to gather information about a patient. And as we've seen in the past 6 months to a year, the Federal Trade Commission has gotten involved in providing guidance to states as well, especially those who are engaged in anti-competitive practices to somehow create barriers or burdens for those using telemedicine as opposed to those providing services in person. So it's important to be mindful that if you are in a position to look at or provide some kind of oversight to licensing boards in your particular state, that you're doing so and being mindful that those particular pieces of guidance or rulemaking or even statutes aren't creating an unnecessary burden or any harsher standards than one might expect for in-person care. And finally, broadband. When it comes to broadband, it really is the infrastructure for all things telehealth and telemedicine. And we certainly can't have a conversation about telehealth adoption and utilization without looking at some of the policies in place that would enable the use of telehealth and telemedicine in your state. There are a few areas that I think states should be mindful of when it comes to policymaking that can help further adoption and utilization of telehealth. When it comes to broadband specifically, there are a number of federal efforts that states can engage in or just engage lawmakers on the federal level, generally speaking, that would allow for additional funding that would allow for better broadband networks in communities, both rural and some non-rural. One to kind of keep in mind is the Healthcare Connect Fund and some of the opportunities for funding in your specific area. It is also extremely important that you should be mindful of how much money is being allocated to funds like this. From 2005 to 2013, it's important to note that $3 billion was unspent on this particular area. And obviously there are many communities throughout the country that still do not have adequate access and availability to broadband services, yet they have healthcare facilities and folks living in residential communities in these particular states. In order to leverage telehealth and telemedicine in today's world, having some kind of broadband access is key. And so encouraging Congress to allocate additional funds to these particular programs so that communities can better leverage them, but also looking at legislation such as HR 2066, which would really look at discounted broadband rates for those in underserved communities to leverage more affordable broadband access for those communities as well. I wanted to highlight these two maps because there's a really cool new tool that the FCC has promoted in the past few months that I would highly recommend that you just kind of take a look at. It's a mapping tool that overlays broadband availability and access throughout the country, and even has more county-level granular data, but overlays that with some healthcare indicators, looking at things like preventable hospital admissions, access to physicians, obesity, and even the rate of an incidence of diabetes in a particular state. What I wanted to highlight here in the first map are those states that have 60 to 100% broadband availability. So these are states that have decent or adequate broadband access, but you contrast that with them also having at a rate of 60 to 100 preventable hospital admissions in those particular states too, which makes you think that if there is adequate broadband availability in those states, to what extent are those facilities not leveraging telehealth and also leveraging their relationships with home and community-based providers to alleviate some of those unnecessary hospital and ER rates. The second map I think is interesting because, again, looking at states that have adequate availability and access to broadband, but again, looking at the lack of physician access, and in this case, states that have less than 70 physicians per 100,000 people in their particular communities. To what extent would adequate licensure portability legislation or some type of network, whether it be on a community, state, or regional level, would enhance access and availability to providers in some of these underserved communities. I also just wanted to highlight one area that I think some states have a tendency to overlook, but at least the federal government has made some enhancements to ensure more availability for health professionals in underserved community. The National Health Service Corps has included language in their grant application allowing for the use of telemedicine to qualify as a clinical service for the conditions of loan repayment. So those states and communities that are trying to attract new talent, particularly when it comes to healthcare, should look for ways to promote these particular programs to attract new talent, and knowing that they can now use telemedicine to alleviate some of these provider shortages. So these are just little ways that states and communities can engage to better leverage telehealth to either attract a growing workforce, enhance broadband, and overall create some kind of availability and accessibility to healthcare services in their communities. I just want to leave you with these final thoughts. This was kind of an animated map, but there's a smiley face there nonetheless. Every state is different. I don't think that we will ever achieve a standardized, universal, countrywide definition of telehealth or telemedicine, nor will we achieve a universal way of delivering care on the part of creating a clinical standard adopted by every state for every licensed professional. But the truth is that we all individually lead mobile life, whether or not we're wearing the hat of a healthcare professional, or if we are a caregiver, or in some instances just a patient. And as such, I think that there's an expectation that our policies remain flexible and adaptable, but also accommodating to a dynamic clinical model and any other kind of patient or provider preferences that may come out as a result of innovation. And so I just want folks to just kind of leave that in mind, that being too prescriptive sometimes stands in the way, and the way in which that we use these technologies should be easy and accommodating for the way in which we live our lives. There are a lot of resources, mostly freely available for download on our website. I think that the nature of these topics could be drilled down into a conversation that we could probably have for the next few hours. But if you'd like more information, I certainly am available, and here's my contact information. But I would love to pass this along now to the next speakers from Hawaii and Alaska, and I'll be available for any questions after their remarks.
Great. Thank you so much, LaToya, for that great overview of the national perspective. I will pause here for one or two questions in the chat box. We received one from Sheila asking for the link to the loan repayment program. So when you have a chance to type that into the chat box, I think everybody would love that.
Sure, no problem.
Thank you so much, LaToya. All right, since there are no other questions yet for LaToya, I'd recommend moving on to the Hawaii presentation, but in the interim, feel free to chat anything in the chat box. We are here and collecting your questions. All right, and I'll give it to you, Lauren.
Great, thank you. Aloha, everybody. My name is Laura Kim. I'm with the Hawaii Department of Health. The first slide that you see in the title there, just want to emphasize that the slide presentation is Hawaii's emerging telehealth environment, and I really want to emphasize the word emerging. The purpose of today's call is to really give us a snapshot of what Hawaii and Alaska are doing. We are struggling to find the right mix of policy and boots on the ground to kind of elevate telehealth to where we think it belongs. And we've got a promising start. And a lot of that is thanks to my partner on the call, this great state of Alaska, and to ASTHO, the Association of State Territorial Health Officials. First, let me just give you a quick overview about Hawaii. There are 50 states. Everyone's unique, but we are just a little more unique, we like to think. We're about 1.5 million residents. We are a minority-majority state, and have been our entire time in the union and before that. We have a foreign-born rate close to 20%. That's higher than the national rate, which just hovers around 12 to 13. The state is called Hawaii. It is named after the people who lived here first, the Native Hawaiians. But depending on how you count it, 10, 15, up to 20% of the population are Native Hawaiian or Native Hawaiian mixed. We are the health state this past year and have been in previous years according to national surveys. And we have the longest living average population at 81.3 years. A lot of it has to do with sunshine, how we eat, our relaxed lifestyle, and various other inputs. We are very remote, so telehealth could mean a lot to us relative to folks living in Hawaii and communicating within Hawaii, but also with resources that are connected internationally and nationally. We are 2,500 is a bit over. It's actually about 2,300 miles from the nearest continent. End to end, the state is about 1,500 miles long, but we basically live on 7 major inhabited islands divided into 4 political jurisdictions or counties. You need a boat or a plane to get from one county to the next, obviously. And again, when my friends from Alaska jump on, that scale of isolation and transportation barriers, you will really get a sense of that. But nevertheless, for us, getting on a plane or a boat is a pretty significant barrier to address access to health care. And just some fun facts to give you a sense of the kind of people that we are here. We have the highest per capita consumption rate of Spam of any state in the Union. We understand Guam is a territory, sort of maybe edges us out as a population center. We are the only state to commercially grow coffee, cacao, and vanilla. And we are literally an island, meaning birds and various other animals that got here were wrasslings. Many of them, and we are the endangered species capital of the world. There's more here as a percentage of wildlife than anywhere else on the planet. What does it mean to practice public health in the great state of Hawaii? We are a single state agency. If you work for the government and you're in the Department of Health, you're a state employee. Our health department encompasses traditional public health programs, environmental management, so the EPA type of programs, clean water, clean air, brownfield, solid waste, etc., and behavioral health services. So we are a fairly large, relatively speaking, state agency that has a variety of programs. And here's the more interesting part that I think is important for listeners to understand as we talk about Hawaii's telehealth strategy. We are a highly insured state and have been pretty much for the past 30 or 40 years almost. In 1974, there was a landmark piece of legislation called the Hawaii Prepaid Health Care Act, the upshot of which is that if you are a employer and you have an employee that works more than 20 hours, you are obligated to fund that employee's healthcare premiums to the tune of 98.5% of their gross salary. And it has resulted in insured rates that are routinely above 90%, up to 96% in one year when we had SCHIP. But being able to pay for health insurance is typically something not seen as a barrier to individuals. Small businesses struggle with it and the cost of care. But we have a very highly insured population with robust health insurance coverage, 25% of which is Medicaid. Like many other states, we struggle with physician supply, especially in rural areas. Most of the population, much of the money, and a majority of the high-paying jobs are here in the urban core on the island of Oahu. There's a fact there. There's a factoid. A statistic there that talks about our actual FTE supply, and more importantly, and germane to this conversation, is our telehealth adoption rate. So we already have a physician supply issue that is further exacerbated by the lack of penetration of telehealth as a community standard of care. As I mentioned, we are Hawaii. There are Native Hawaiians here. Unfortunately, it's a very sad story that has repeated itself across the globe. Issues of colonization and native populations that have been dispossessed, disenfranchised, and suffered culturally, despite having very high insurance rates across the board, despite having long average lifespans, and despite having tremendous weather and just a general good attitude of people here. Native Hawaiians routinely find themselves at the bottom end of many health outcomes, social economic status. It's something that I think is not unheard of when we look at, for example, Native Hawaiian populations, Native American populations across the continental U.S. So we have a lot going for us, but we certainly have our fair share of challenges. So what does it mean, telehealth? And I characterize it as an emerging telehealth environment. We have a couple of really good shining stars here, our Hawaii Telestroke Network, the Shriners Hospital for Children, the VA, Department of Defense. Those systems, I think, do an excellent job of leveraging telehealth. Here at the Department of Health, we are beginning to grapple with telehealth as looking at telehealth as a broad public-private strategic opportunity. And again, we do have some shining stars, our Child Adolescent Mental Health Division, telegenetics program. We have adopted New Mexico's Project ECHO to great success. But I guess the point of the slide is that there are pockets of excellence here. I wouldn't characterize our state system, and as you've seen from our less than 5% telehealth adoption rate, as a case study in telehealth excellence. But we have recognized, I think, what we need to do, and we are beginning to organize ourselves, and that's going to be the point of the remaining slides. LaToya's presentation was a tremendously helpful survey of our 50 states. If you look at the 2016 Telehealth Gap survey that's on the website and that she alluded to, Hawaii is kind of sort of in the middle of the pack. We've had a law in the books for a while. I think it's since the early 90s or late 90s. That was recently updated in 2014. That probably shot us up to the middle, whereas otherwise we probably would have hovered in the lower tiers. And it was a private sector reimbursement bill that I think those of you in the telehealth policy or public policy domain have seen proliferate across the country, focusing on primary care, mental health, and oral health, expanding the categories of qualified providers, and putting in what I think is emerging, what is an emerging consensus as barriers to full adoption, meaning there were restrictions in certain requirements for provider-patient relationship, the presence of a provider at both ends of the call, so on and so forth. Nevertheless, it was a landmark policy advancement in Hawaii. But as LaToya's and the ATA's gap analysis states, we got an F for opportunities in Medicaid. We went ahead and fixed that, so LaToya, I hope you'll give us a better grade on that in the 2017 or future gap analysis. The Governor Ige enacted SB 2395 as Act 226 just a couple of months ago, basically getting rid of restrictions on originating site requirements. The patient could be in their home or office, and the provider may be reimbursed for that service. A real significant barrier that I did not see mentioned, at least in the telehealth gap analysis from the ATA, was the extent of malpractice coverage. Anecdotally, this has been very problematic for Hawaii providers. And SB 2395/Act 226 compelled liability insurance providers to provide malpractice insurance for telehealth in an equivalency to face-to-face coverage. And again, for our provider community, this was very significant. So we removed that as a barrier or excuse to adopting telehealth. It includes almost word for word the industry standard definitions for the 4 domains of store and forward, remote monitoring, live consultation, and mobile health. So it's a very forward-looking bill. Mobile health, I think, is something that we all know is on the horizon. There are rules and regulations that we need to promulgate to get a grip on that. But with apps and smartphones, our law has built in a degree of future-proofing, which we think will be very, very helpful. And it removed the existing provider-patient relationship requirement that our 2014 Act required. So that we believe we have a tremendously progressive and flexible telehealth environment, as well as requiring the written disclosure of telehealth benefits from managed care companies. Patients need to know that this is an option, and we think that that's very helpful. Telehealth became an official state strategy, a core strategy as the result of some of our healthcare transformation initiatives that coincided with the implementation of the Affordable Care Act. So it is many of these bills can be seen as being part of that continuity and that continuum of emerging telehealth awareness and policy development. And I really need to give a shout out to ASTHO for the opportunity for technical assistance they provided for us earlier this year. As a direct result of ASTHO's assistance, telehealth became a department strategic priority. I just want to, provide a little bit of a commercial for a bill that is been referred to committees in the United States Congress that was sponsored by our congressional delegation, specifically Senator Brian Schatz, the Connect for Health Act, Senate Bill 2484. That is something that we think will sort of loosen telehealth, the Medicare environment for telehealth. And as Territorial pointed out, we are currently examining Hawaii's future participation in an interstate medical licensure compact scheme. Licensure reciprocity is fraught full of local political difficulties about turf and terrain, but I think everybody recognizes that it is a legitimate option, and Hawaii is going to take a look at it, or my department is going to take a look at it, in the hopes of having a meaningful discussion at the next legislative session to see how we can make it work for Hawaii. As mentioned, it is now, telehealth is now one of our top 3 priorities for the Director of Health and the Department of Health, and I've just provided a snapshot of our strategy map. As a result of our technical assistance from ASTHO, we really saw the need to pull together, we really recognized the need for state leadership. My internal group really struggled with, do we really need another working group, another strategic plan? We wrung our hands about it, and we've got so many of these plans and so many of these groups, and with the advantages that we have here in our marketplace, can't this just happen by itself? Can we connect those dots at the last mile, and can't something just magically appear? Well, no, that was our conclusion, and thanks to the example of Alaska, which I think you're going to hear in greater detail, some state leadership we've come to realize is absolutely essential. That last mile of connecting providers to resources and patients to providers clearly isn't going to happen by itself. Nothing worthwhile doing in public health has happened without state leadership, public-private partnership, goals, plans, and objectives. All the sweeping public policy reforms that I do in my other job as being the legislative liaison really isn't enough. We do need the power to convene that departments of health and state health officials have to bring folks together to make those community standards happen, to address the underlying concerns. And as a result, the state of Hawaii, through the Department of Health, will be pulling together the Hawaii State Telehealth Council. The first step in that will be to secure and fund a full-time Hawaii State telehealth coordinator to staff it. And we want to look at various tipping point projects and get the input of our legislature and get their participation and buy-in, literally buy-in through seed money or demonstration project money, to push our market, which we believe is just shy of a tipping point. We've got the insurance coverage, we've got a robust policy framework, as just described in my previous slides, and we've got pockets of excellence. What is it going to take to overcome the past experience of providers who may have been burned either on the technology, or they haven't been paid, or there weren't enough resources to transform their practice, or to compete with all the other priorities that providers have with ICD-10 and HIPAA and everything else, and healthcare transformation in health homes? Who is minding the store for telehealth, and what are those things that can prove to patients and providers that a little effort goes a long way with telehealth? We're looking at virtual dental homes, traditional rural extensions into the rural community, home visitation. We have a particular focus on early childhood health and as it relates to substance abuse and reproductive health. So we're looking at screening, brief intervention, referral, and treatment. Planned Parenthood, we plan to have a conversation with them very soon. If you haven't heard, Planned Parenthood has some great apps called Planned Parenthood Direct and Planned Parenthood, I think, Care, or Planned Parenthood Health, that allows contraception, that allows for connections to contraception access and reproductive health consultation via secure smartphone app. And we would like to have a discussion with the local Planned Parenthood affiliate about how state assistance, funding, emerging developing community standards of care could facilitate that as it relates to early childhood health and, of course, to telehealth. And we have been kicking around for a while internally with our partners, community paramedicine. If you're not familiar with that, this has to do with looking around, particularly in rural communities. Well, in Hawaii, let me preface that by saying we have a 24/7 professional full-time EMS system. Whether you live in a small rural community or urban Honolulu, within 20 or so minutes you have a professionally trained, full-time salaried EMS A or B or higher available to you in an ambulance station, in an EMS station, or a hospital. So perhaps in areas where the number of calls isn't as frequent as the urban core, those trusted community residents and those trusted community resources, EMS and paramedics, EMS techs and paramedics, can we use telehealth apps, broadband connections to examine quasi-community health worker roles, in-home visitations, so on and so forth. So we're sort of excited about those. These are all in the planning stages that we need to sift through and prioritize. I want to make specific mention of enforcement. Our provider community is quite interested in knowing, now that we have these laws, are the managed care companies and various other third-party payers and malpractice insurers actually following through? Is there actual parity? Surveillance and enforcement is something that the Department of Health needs to cooperate with licensing boards and professional organizations to make sure that happens. Again, it's not good enough. We have realized it's not good enough just to have sweeping public policy changes and a positive public policy environment. This gets down to the nitty-gritty. Anything we've ever done of value and success and magnitude in public health, whether it's smoking or seatbelts, gets down to one patient, one provider, one resident, and their experience. And we need to build out that system. Lastly, another idea that we definitely need to look at is to leverage the state's influence as a purchaser of healthcare. For example, would it be worthwhile to write into our public employee contracts, or perhaps our Medicaid contracts, that health plans, and we have a managed care environment here, health plan vendors must achieve a 5% or 10% or X% penetration rate with their provider network in telehealth adoption. These are all concepts. They haven't been vetted yet, but these are ideas that we hope would inspire you, other folks on this call, or if you have experiences, we'd like to hear from you on that. The next slide are just some references that I've used throughout the slide deck. If you, I'm sure many of you are on this call, spend part of or most of your time on telehealth, and if you have a regional telehealth resource center, they are absolutely invaluable, as well as the American Telemedicine Association. My contact information is there. I cannot wait to pass over the controls to the great state of Alaska, who has done just tremendous things and from whom we've learned so much. So that's my snapshot of the state of telehealth in Hawaii. We've got a ways to go, and we have a renewed sense of urgency about telehealth, and we have appropriately prioritized it as one of our strategic objectives. So that's it for me. Thank you.
Thank you, Lauren, and thanks for that great presentation. I'm Jill Lewis, Deputy Director for the Alaska Division of Public Health, and I'm going to start off our presentation and then hand it off to Christiane. One of the things to understand about why telehealth is so important in Alaska is to know a few things about us. We are the largest state in terms of area, covering 20% of the U.S., but we're also the smallest in population density at only 1.2 per square mile. You can see that our population is centered at nearly half in one population center, Anchorage, our largest city. And then in our top 5 cities, after the third city, you don't even have 10,000 people anymore in our largest cities. We have about 15% of our population is Alaska Native and American Indian, and they live all over the state. We don't really have reservations except for one very small one at the southern tip. Part of how far apart we are, just to illustrate myself, I'm located in southeast Alaska, so is Christiane, roughly about where Atlanta is on the map here. And my boss is in the equivalent of Kansas City, so some 600 miles away. Alaska isn't just rural, it's actually still a frontier. More than half of the state has no local government and relies on the state government for all of their services, from education to public health, things that you might often find in a county or a regional health department. We do have one local public health department in our largest population center in Anchorage, but other than that, public health is provided entirely by the state government. And the tribal system has a very robust community health system that performs many of the functions that you might normally find in public health. We have a lot of geographic challenges in addition to the size of our state. Few of our areas are connected by road, and many areas still lack running water and sewer out in the rural areas. When you put the great distances, the rough terrain, the extreme weather, and the lack of infrastructure, it makes it challenging to even get the basic health care in many areas. And as Lauren said about Hawaii, the same holds true for Alaska. For most folks that are outside of the largest cities and on our limited road system, their only option is to travel by boat or by plane. It also is challenging to attract a lot of specialists and primary care physicians to Alaska. Most of the physicians are found in the few urban areas. Partly that is because of our low population numbers to establish practices, and partly it's the high cost of living. And some folks really don't want to practice in an area that is as remote as many of the places that we have. Just as an example, even though Juneau is our third largest city and the state capital, we don't have a cardiologist, an oncologist, or a dermatologist here. So it requires long and costly trips to get to an urban hub or to go to what we call the lower 48 states, the lower 48, to get that kind of specialty care. And the only option you have is to take that kind of a trip unless you can connect these rural clinics and rural providers with telehealth. So I'm going to hand it off to Christy Ann, who will talk a little bit about how the tribal health system pioneered telehealth in the late 1900s and the partnerships and the statewide leadership which led to the tribal telehealth network being developed.
Thanks, Jill. Hi, everyone. I'm Christiane Stapp, and I'm going to talk, as Jill said, I'm going to talk a little bit about the history of the Alaska Telehealth Advisory Council, which really was the key governing group that helped to develop and build out of our telehealth system, which is quite extensive and was really ahead of its time in terms of the rest of the country. But it's built out through our tribal health system, which involves 29 different tribal health organizations. Tribal health is done quite differently in Alaska than any other state that I've been in. And these are well-organized systems, each with their own leadership. And so they come together through the governance or through the assistance or governance of the Alaska, the ANTHC, which is the Alaska Native Tribal Health Consortium. So essentially, as Jill said, in like the late 1990s, Senator Ted Stevens, who was a staunch advocate for Alaska, managed to get a congressional appropriation in excess of $30 million for Alaska, specifically for the purpose of developing a statewide telehealth system. And the Alaska Telehealth Advisory Council was the key group that helped to actually facilitate that project. It actually initially started as a commission that was just supposed to meet for 6 months, like a lot of committees are supposed to do. It was supposed to quickly get in there and establish some objectives, but it didn't take too long for them to determine that the objectives really were long-term and best served by an established council to help facilitate the project being the Alaska Federal Healthcare Access Network, which is the telehealth system that's been developed across the tribal health network. I'm going to talk about the history of this organization, the history of this group, and I'm going to talk about some key takeaways as well that still stand true today. The members were designated by Senator Stevens, so this work was backed by the most executive leadership in the state, and so which is really important when you're considering, deploying a statewide system that's going to be a public private partnership. He also designated the co-leaders of the group, the co-chairs, which were the Commissioner of the Department of Health and Social Services and the CEO of the Alaska Native Tribal Health Consortium, which we call ANTHC up here. The council had a budget of about $100,000 per year, maybe a little more than that. It had a paid facilitator, and that person was a physician champion, and that's a really key takeaway in all of this. And in addition to 2 state agency professional staff that help staff and facilitate the work of the group. However, the work of the project itself, the build-out itself, actually involved many more state staff and partners over time. So there were a lot of FTEs that went into deploying this project and into the work of the subgroups. And in addition to the core council, there were 5 subgroups formed, and you can see there were key areas that they were supposed to address here, legal issues, fiscal issues, and so on. They also, all the groups together also, an important issue that was and is still an issue is the issue of technology and technological build-out and development and capacity and barriers. It's important to note that the work of creating the network involved a lot of small pilot projects along the way as the priorities and opportunities were identified. So it was really an intentional, deliberate build-out, and this really allowed for ideas to be tested before they were further deployed. The group met from 1999 through 2000. The purpose of this group was to facilitate the establishment of the Afghan Telehealth Network, and that was really, once that infrastructure was put in place and it was established in a governing body and where it was going to be operationalized, the group dissolved. The key leaders of the group were, as I said, they were selected by Senator Ted Stevens. And the appropriate membership of the group was really a key element to the success. And it included decision makers. I'm going to emphasize that. It included decision makers from across the healthcare spectrum. It also included leaders and decision makers from the technical industries as well as academia. So all aspects of project development were considered in the process of forming this group. This included the research aspect, which is really important, that issue of defining and measuring outcomes. This is where university partners can be very helpful because, as I've heard it said, you don't get what you want, you get what you measure. So having objectives and measurable outcomes is really important in defending and building your work. The telecom industry was also, that their involvement was essential. There were and are extensive bandwidth, connectivity, and technological issues faced by the states. And so having them at the table, and again, that executive leadership and decision makers able to affect change were really important. Healthcare advocacy stakeholders, particularly those with key relationships with providers communities, are also essential. So basically having champions in all these areas is essential because developing a system like this depends on strong relationships and partnerships. This also helps facilitate the process of communicating consistently across the network of stakeholders that could be impacted by this work. An endeavor like this requires the buy-in not only of government and industry leaders as well as healthcare providers, but really that of communities and individuals who will be accessing these services. Those are ultimately the customers to be served by the system. So one of the key activities of this council was to establish a clear statement of purpose as well as some core principles for guiding the work. This group worked to define a specific mission and objectives to work toward. This is important because these are the unifying values and objectives that help keep the group and the work cohesive and work moving forward. So some of these statements still very much apply in Alaska today. There are still barriers and obstacles that exist. There still is the issue of how to evaluate effectiveness and also how to address health equity and how to measure whether or not we are addressing health equity. One key issue right now on our table is the framework for further development that is sustainable. Sustainability is a big issue, as well as trying to keep up and navigate changing technology and assist the provider network with that process. The core principles established, these are the core principles established by the Council. These are guiding values, if you will. Again, these are still very much relevant today. Interoperability is an ongoing issue, as well as access, especially when you consider the variation in technical and bandwidth capacity across the state that can be hit or miss on any given day, especially in a state that is so heavily impacted and influenced by weather systems, and a limited ability to deploy technical assistance out there in the field. So use of equipment and applications can also still very much be an issue. Organizations that have a dedicated approach to telemedicine and have incorporated dedicated policies, procedures, training, and support, particularly the IT and technical support, tend to be more successful in having, having telehealth actively engaged within their organization and not having it become basically equipment that's hidden away in a closet somewhere. That doesn't happen as often maybe as it once did in Alaska, but that's still very much an issue when people who don't know how to engage this technology and don't necessarily feel supported in doing so. Financial sustainability is also still an ongoing issue. There are some excellent training and program support resources that have been developed in Alaska. However, they reside within Afghan, and that staff is overwhelmed supporting the tribal health telehealth system. So they have limited time and capacity to really help us with any further development outside of the telehealth system, outside of the tribal health system. So these core principles are still very valid today and can be applied to the work that is still needed in Alaska. So having an established group of key decision makers that is fully supported by the executive leadership of the state, as well as dedicated staff and a clear unifying vision and specific objectives are some key takeaways from the work of the Alaska Telehealth Council. And I'll turn it back over to you, Jill.
Thanks, Christiane. So as Christiane said, our tribal telehealth network, a very robust system, resulted from the Commission's work and has been in place for quite a long time now. But it does largely serve only the native system in our state because we have so many limited providers. Often in the rural areas, the only health care that is available is the tribal health care system, and they do see non-tribal beneficiaries in that case. However, those folks cannot really be referred when there is a private option, so it isn't, even though they could be seen locally, it isn't really a system that non-tribal beneficiaries can access. And as I said earlier, about 15% of our population is Alaska Native or American Indian. So it is still leaves a significant gap in our system. And just to give you an idea, in case you were thinking that maybe there's only a few things or you couldn't think of very many things that you could actually do with telehealth, these are some examples of what the Alaska Tribal Telehealth System does with live video conferencing. There's even more things that they can do with the store and forward technology, such as diagnostic imaging and teledentistry that they do. This large map illustrates the hub and spoke delivery system that the Alaska Native Healthcare System uses. They use this both in their clinics and in their telehealth system. All of this leads to Anchorage, where the large Alaska Native Hospital and Medical Center is located. In contrast, the small inset map shows the federal highway system in Alaska. And so that's it. That's all we have in the terms of a federal road system. There are other roads, and communities themselves have roads, but they don't link to each other. And so obviously, you know, access is very limited, and it can take more than a day, even if weather doesn't impact you. Just to travel in from one of the remote areas, it can take you a day to get to the hub. If you need to be referred to Anchorage, it can take you another day. If you got your appointment, you may need to stay over again in another hotel, be seen the next day. Perhaps there's follow-up care. It could take you days or even a week if the weather cooperates for you to go to a routine follow-up visit that just required your provider to see you for 15 minutes. So telehealth is obviously a very important piece of what we need for rural health access. And because the tribal system is so robust, they can provide services across the state and avoid a lot of that costly and unnecessary travel. However, because the non-tribal health system is fragmented and limited across the state, a lot of our non-natives can't participate fully. So our goal is to expand telehealth in the non-tribal sector. We do have some community health centers, hospitals, and not so much interest from private practice. The Medicaid reimbursement is as good as an inpatient visit, so that is good. And the state of Alaska itself uses telehealth for a number of things: behavioral health, long-term care assessments, and distance learning, and we have some pilots on veterans' access to behavioral health that uses telehealth. Largely, the barriers to expanding have been concerns over cost of the systems, competition, our lack of bandwidth, and privacy concerns. Lately, we've seen a shift in some policies in our state that have opened up a window that makes expanding telehealth into the non-tribal sector a little bit more viable for us. One is a massive budget shortfall. We have 90% of our state general funds are generated from oil revenues, and so our operating budget is about $5 billion, but we only have about $1 billion in general fund revenues. So there's a lot of interest in doing innovative things that will save both the state money and healthcare systems in general. Telehealth is seen as a way to lower healthcare costs for the Medicaid program, state employee and retired health plans, and the correctional facilities. And that way help our state budget. Another shift in policy was a major healthcare reform bill that was passed in the last session that expands the use of telehealth. Mainly, the legislature saw this as a reform bill that would reduce healthcare costs. It removes a number of hurdles from telehealth use and is projected to save about $13 million in avoided travel by 2021. You can see some of the provisions here. So next, Christiane will round out our presentation and talk a little bit about the next steps on where we go now that we have the shift in policy.
So out of SB 74, there are 16 work groups that are going to be taking on the issue of marching out the work of SB 74 and the overall Medicaid redesign and reform process. One of those work groups is focused on telehealth. But as Jill explained, Alaska is affected by a much different economic climate these days. We don't have millions of dollars of appropriation to look at building out a system. So, I mean, the state is in an active economic crisis. So the focus is really on how telehealth could potentially help with healthcare cost containment and more effective use of resources, particularly around the areas of primary care, urgent care, and behavioral health. Some of the surveying work we've done in public health shows that our primary care providers are very much in need of being able to connect and very interested in connecting their patients to specialty care and behavioral health. So being able to adequately support our primary care network and also being able to expand access to care at lower levels is really a focus of the work. So the initial work, though, of the telehealth work group will really focus on evaluating these key areas that I've got highlighted here on this slide and making recommendations about what might be possible and how to proceed, including what kind of cost and investment that might be required in order to do that, and where maybe there are key areas or opportunities to be able to maybe do some demonstration projects or do some minor pilots and building things out. There are a lot of challenges to be addressed in moving forward with any further development, especially, as Jill has said, in the 9-tribal provider network. And so in some ways we're at square one with that group, but we've got this amazing history to benefit from and lessons learned. So the next year will really be spent on doing a lot of information gathering and some in-depth deep dive in evaluation and formulating some recommendations back to our legislature and in order to figure out how we're going to build this out going forward. Thanks.
Great. Thank you to all of the 4 presenters for their very informative, engaging presentations. We'll now open up the Q&A to participants. If you'd like to ask a question, please type it in the chat box located on your screen. Some of you have already started doing that, so thank you. We will also ask the operator to provide instructions for how to unmute your phone line if you'd like to ask a question. Operator?
Ladies and gentlemen, at this time, if you would like to ask an audio question, please press star followed by the 1 on your telephone keypad. Again, that is star 1.
Great. Thank you. So let me start off with some of the questions that we've already received so far. Someone says, I'm not familiar with malpractice coverage for telehealth as a barrier. Do typical malpractice insurance packages not cover telemedicine? So I believe this is a question that was prompted by your presentation, Lauren, where you talked about the new legislation that addressed this. But if you have, LaToya, if you also want to chime in here based on your experience at the national level.
Yeah, let me go first because I would imagine, this is Lauren from Hawaii. I imagine LaToya's probably got a more informed view. As mentioned in our presentation, anecdotally, when we were trying to move the bills through the legislature, and so we were doing some preliminary discussions with stakeholders, and even in a former life in managed care, how telehealth was defined was very important to malpractice insurers. Was it a version of online care? Was it a secure system? So purchasing coverage of routine or normal malpractice insurance, apparently, and again, I'm sorry, I haven't done the research myself. This is what we've heard from our provider input, provider stakeholders input. Was either a rider or it was priced outside of what routine malpractice insurance or face-to-face coverage would be. So it was treated as something distinct and separate, priced differently. We are still trying to get to the bottom of why that was the case. Was it truly risk management? Was it an issue of education? Was it a hangover from early periods of time when calls would be dropped or clarity of video and audio may have garbled the message? As mentioned, that has been taken off the table with with our recent telehealth acts in 14 and 16. But I'm sorry, I don't have much information on the specifics, but certainly that has been a significant issue both from the provider community and from the managed care community.
Yeah, and this is Latoya from ATA. What I'll add to that is that because the coverage is regulated by the state, every state's a little different. I think that Hawaii's approach to that was unique because of the concerns, as Lauren pointed out, were on the part of the providers that they heard from and some of the barriers that they were encountering in using telehealth. We have not encountered similar challenges in other states. But as folks continue to, develop new clinical models, you never know what might come up. But certainly this particular statutory provision was unique to Hawaii.
Great. Thank you, Lauren and Latoya, for those insightful answers. The next question I'll pose to the presenters is about the opportunities for mobile apps, but also as it relates to cellular data coverage. Participants interested in whether mobile apps are something that Alaska has considered, but whether that would be hampered by potentially gaps in, cellular data coverage. So I'll turn that to Jill and Christiane.
So I don't hear Christiane jumping in, so this is Jill, and so I'll give a stab at this. In Alaska, there are some coverage issues for cell phone usage, and it varies widely across the state as to what kind of, who your coverage is with. I know that apps are being looked at in the tribal system and explored at this point, but for the most part, they are using a clinic-based model, but they're moving out and exploring models that aren't dependent on your location, that are more mobile.
Hi, this is Christiane, and I'll jump in there. So there are some, my understanding is there are some use applications, especially more, to support the physician and some communication there within specific organizations. And there is some use of mobile technology that has been tried in terms of trying to do some home health-based stuff for kids with disabilities and using their iPad and doing some of those other kinds of innovative approaches that are being tested and used and tried, but there's been a lot of challenges. Again, it goes right back to bandwidth. Sometimes it requires too much data draw, and so when you're doing sessions like that, what I've heard is that one of the struggles is that there's this delay in video time and it results, and so it winds up being a very disruptive encounter, and it's not been very effective. So it's still very much being worked out and tweaked because, again, as Jill said, our areas often of the most need are the ones that struggle with the most with connectivity.
Okay, thank you both for that answer. My next question will be around sort of the education and awareness among both providers and patients about this technology and its capacity. Lauren, you spoke a little bit about working with providers, and I know as part of the Alaska Telehealth Advisory Council, I'm sure there was some part of education and like that. So are there any best practices for sort of describing telehealth, explaining its possibilities, and promoting its benefits? So I'm opening it up to all four presenters. right, I don't hear any takers. Okay, I guess we can, while you move on that question, we'll direct it to another one. You mentioned that moving forward, you both have discussions and you're planning to convene different types of work groups to promote this work. And you mentioned a number of different key partners. And can you talk about strategies to engage either individuals within your organization and health departments or Medicaid agencies, or as well as strategies for engaging folks outside of your organization, such as health systems or other organizations?
Hey, this is Latoya from ATA. I mean, I can share with you some of the practices that our members are engaged in. I would have to say that transparency is key. As much as telehealth and telemedicine and any iteration of the terms are becoming more well-known, or at least lawmakers are becoming more aware of the clinical models, they don't fully understand every instance of how telehealth is used, or how sometimes it's used in some of the untraditional healthcare senses. For example, when telehealth is used in a patient's home or in a residence, when it is used for instances of an emergency, when the patient can't necessarily consent to a specialist providing a consult, when they're admitted to the emergency room. And so if you're engaging in telehealth, or if you have tried a particular clinical delivery model and you're unsure as to whether or not it is clinically permissible by our state licensing board, to what extent it is covered by a health insurance company, or if there is appropriate oversight by a state agency, or if it's got any value at all, presenting that information to the entity in question and being transparent about the process is far better than working on it and then figuring out at the end of the day that you've done something that may not have been legally permissible or not covered or reimbursed by a particular health plan. Just so education and transparency, and of course being compliant with any state or federal laws and educating that to lawmakers is extremely important and effective.
Thank you, Latoya. That's really helpful. At this time, I'd like to ask the operator if we've had any questions via the phone line.
And at this time, there are no audio questions.
Great, thank you. All right, so we'll go back to the questions that's come in through the chat box. As far as educational tools for patients as far as consent, are there any best practices that you, either Alaska, Hawaii, or Latoya with ATA have come across about this process?
This is Latoya from ATA. I'll chime in again. It's interesting, folks. We get that question a lot, and I often answer that. I don't think that anyone has fully figured out how to effectively change patient behavior in healthcare. And when you integrate technology and telecommunications in that, despite the fact that mobile devices are ubiquitous and folks have access to some broadband and internet interventions, we still have not completely figured out how to get folks to adhere to treatment using the technology. How do we get them to share information, whether it's patient-generated or to what degree it's patients, logging into a portal, getting that information, sharing it with other healthcare providers that might be a part of that team. And so I think it's ongoing. There really is no one-size-fits-all answer, especially when using the technologies and telecommunications. And I know that there have been some models that have been successfully used integrating the technology, like the ECHO model, the interdisciplinary model for subspecialties. It's been effective on the state level. There's a lot of evidence-based outcomes related to that, and has been pitched now to some of the members of Congress as a model worth considering for CMMI. And then there have been folks who have looked at interventions like home health and the use of remote patient monitoring for chronic disease management, and leveraging home health nurses and home health aides, not just in the monitoring or self-monitoring of vital signs, but their role in educating patients on the use of those devices to self-manage and self-monitor. So I think it really does depend on the clinical model and the way in which we use these tools to effectively change patient behavior so that they're adhering to care.
Great, thank you so much, LaToya. All right, so I'm going to ask one last question before we sign off, and that is about what do you think that moving forward, either your state or resources that you think states would be helpful to have regarding telehealth? I know you shared a bit about your experience with receiving ASTHO technical assistance, but I know as these programs continue, I'm sure you'll identify other needs, and so just thoughts about that, about the larger telehealth context would be much appreciated.
Hey, Emily, can you repeat the question? I missed some of that.
Sure, definitely. So this is a question regarding sort of what our states and perhaps other participants on the call might have ideas for resources that they would find helpful with their telehealth initiatives. And I was posing the question to either Hawaii or Alaska, thinking about moving forward, what are other technical assistance opportunities or resources or questions that they may have about telehealth and how it might work in their state.
I don't mind getting started on that. Outside of the American Telemedicine Association, which is a really great resource, I highly, highly encourage folks who have registered on this call to reach out to their regional telehealth resource centers. They're entities who've been funded by HRSA all over the country, whose role is to provide technical assistance when it comes to the adoption of these technologies and platforms, but also to the deployment for them and going through that level of assessment. So I highly, highly encourage you to engage with these folks. And I believe that their website is telehealthresourcecenter.org. And you're able to find the resource center in your area if you just kind of search by your state. Again, the American Telemedicine Association. One other thing just to be mindful of, that throughout the country, because telehealth is becoming an area that lawmakers are becoming increasingly interested in, we have noticed that lawmakers are, through legislation, developing statewide telehealth task forces, or they're allocating funding to support the deployment of statewide networks. And to the degree that there is one that exists in your state, we've highlighted some of them in the GAPS reports that I highlighted in my presentation and as did Lauren in his presentation. Our GAPS reports on coverage and reimbursement include some information about a statewide task force, statewide commissions, or statewide alliances in your state that are having multidisciplinary conversations about the deployment and adoption of telehealth in particular states. And so I encourage you to get engaged with them. I know that Florida is gearing up for conversations about telehealth throughout their state in the next couple of weeks. There are states like Louisiana that convene on a monthly basis, as well as New York that convene on a monthly basis to talk about the various policies and regulations that are going on in their state, but also to share best practices. And so you can always come to ATA as a resource to get more information about that. And I also mentioned at the beginning of my presentation that we're hosting a Southeastern State Policy Town Hall in conjunction with our fall forum this year in New Orleans. So obviously reaching out to both of the entities from Hawaii and Alaska for more information about their respective states, but there are a lot of freely available resources out there.
Great, thank you so much, LaToya. So I find ourselves that we're out of time, and so at this time I think we'll end the Q&A. And for those who we weren't able to answer your questions, we can definitely try after the call to look up some answers for you and resources. If you have any follow-up questions, please reach out to us. Our emails are on this slide. My name is Emily Moore. I'm here at ASTHO. And thank you again for joining us today. As was mentioned earlier, you'll be immediately directed to an evaluation at the conclusion of today's webinar. please take a few minutes to complete our survey, as it really helps us receive information about future projects as well as ideas for future technical assistance if you have any. So please take a few minutes when you have a chance. I'd also like to thank our 5 speakers, LaToya Thomas, Lauren Kim, Jill Lewis, and Chrissy and staff. It was an incredible experience having you on today, and so thank you so much. And I hope everyone enjoys the rest of their day. Thank you again for joining, and hope to see you in another ASTHO webinar. Have a great day.
Ladies and gentlemen, that does conclude today's webinar. We thank you for your participation and ask that you please disconnect your lines.